Joseph Lee Hollander Chair in Pediatric Rheumatology at Children's Hospital of Philadelphia. Dr. Behren's research focus is the pathogenesis and treatment of cytokine storm syndromes, including the HLH and the MAS. He is specifically interested in dissecting the initiating, propagating, and regulatory factors that determine the pace and outcome of cytokine storm, and this he has accomplished mostly in different murine models. The ultimate goal of these investigations is to improve the lives of patients that suffer from cytokine storm syndrome by developing strategies for treatment and prevention. And as we heard Chandrika say in her talk, it's always better to approach these children as a syndromic approach rather than getting into the nitty-gritty of etiologies. So Dr. Behren's talk is on the management of cytokine storm, the rational approach of choosing the right modality and having a syndromic approach. Over to you, Dr. Behrens.
All right, thank you very much for the invitation to speak. And yeah, so, I've been charged with trying to think about or speak about, immediate management of cytokine storm and choosing the right modality. And I think I'll touch upon actually a lot of the things that we heard about from the previous speakers. So, and I guess, what I'm going to share with you are some techniques that we're using at the Children's Hospital of Philadelphia, which I recognize make use of some technologies and techniques that may not be readily available globally, let alone not even necessarily readily available in other centers in the US. But I think that there's some value in sort of hearing about our approach, because I think that there are some unique things that we're doing that I hope can make it out to other places that that might eventually help us do better for all these children. So I think what we really need, and we can use different words, whether we want to say we want to take a syndromic approach or whether we want to take a diagnostic approach. I think what it comes down to is what we need is a precision approach. And this comes from the fact that we need to make rapid decisions really in the absence of good randomized trials or other high quality evidence. I think because these are, as we've heard over and over again today, difficult to diagnose, lots of overlap between different syndromes, it's really hard to do good randomized trials for these populations. And so in the absence of having the definitive randomized clinical trial that tells us, here's what you do for this patient every time, there may be an opportunity in trying to sort of profile the physiology of the patient in order to make a semi-rational choice with the overwhelming number of different medicines or approaches that one could take. And I think in combination with clinical pattern recognition, the sort of syndromic appearance of the patient, immune profiling can provide a framework for making these therapeutic choices in a rational way. And I think when you get down to it, the dilemma really comes from the fact that we have very divergent choices to make, right? If our choices were all just subtle differences, all within the same category of therapy, this might not be any big deal. But the truth is making the wrong choice at the wrong time could have bad consequences. And we really have very divergent choices to choose from. So when you're thinking about the hyperinflammatory aspect of these cytokine syndrome patients, what you're really looking to do is control the runaway immune response. And then within that, there are different flavors of the immune response. So, it's not just, steroids or etoposide, but the opportunity to potentially block different immune pathways or cytokines. On the other hand, if your problem is infection, then, your immediate action has to be source control of that infection. It does no good to treat the immune system if you don't eliminate the source of the problem. And sometimes manipulating the immune system may cause the problem to be worse, because really what you need is source control of that infection. And so you want an intact immune system. So there's a divergence there, whether you're treating the immune system or whether you're treating with antibiotics. Another example is, metabolic disease can often present with many of the same features as infectious or hyperinflammatory cytokine storm syndromes. And there you're looking to restore the biochemical derangements, whether you're talking about rare things like lysine uric, protein intolerance, or other inborn errors of metabolism that present like cytokine storm, but actually are issues of the metabolic state of the patient. And then the perhaps the most difficult piece is there is overlap of even these different kinds of syndromes, right? So we've certainly heard a lot about how infection and hyperinflammation go hand in hand, particularly for certain pathogens. Sometimes the hyperinflammatory state leads to an infection because that immune dysregulation is a setup for acquiring an infection that might not otherwise have gotten. Being in a deranged metabolic state certainly can predispose you to infections or make your immune system hyperactive. And so, you're not always making a discrete trinary choice of these three things, but sometimes you have to deal with the fact that there's overlap. So, on the one hand, there's an attraction to say, gosh, we just need to figure out like what are the defining clinical features that are going to let us separate these groups, right? But I think the on the other hand, we have to recognize that there is a lot of overlap, and that's what makes this so difficult. There is a lot of overlap in the clinical syndromic phenotype in all these different scenarios, right? They all tend to have acute multi-organ failure. And I wholeheartedly agree that hepatitis is, a fundamental feature of HLH, right? I mean, that my lab is like hyper-focused on this exact point. I have a hepatology fellow in my lab right now working on these very issues. But you're going to get hepatitis in metabolic disease. You're going to get hepatitis in, systemic infections. And so I don't know that necessarily cues you in to one particular flavor of the cytokine storm. It's already been mentioned by our previous speaker that, hemophagocytes aren't necessarily the end all to be all in terms of diagnosis, but there is this sort of hemophagocytic subgroup, right, that we associate with cytopenias and fibrinogen consumption and hyperferritinemia. And so there is that kind of syndromic appearance there when you see all these things together that puts you more in the HLH macrophage activation syndrome like physiology. The other sort of syndromic phenotype I think about is what I call the endotoxin phenotype, right? So this is the patient that has this out of proportion, poor perfusion, vascular collapse, often neutrophilic because it's associated with infections that are driving neutrophils, but can have labs that look like hemophagocytic syndrome as well. But I think what marks these patients is the really extreme cardiovascular collapse that these patients get. So these sort of clinical syndromic phenotypes, I think, are somewhat helpful in helping you to A, choose a pathway, and then B, pick a therapy. But there's certainly a lot of overlap in all of these things. And so, I'd argue that syndromic assessment is important. It certainly puts you in some region of the map for thinking about where your patient sits in the cytokine storm spectrum. But my concern is that it doesn't necessarily get you close enough to really make the kind of rational decisions we want to make about medicines that sometimes come with high risk and high toxicity. And so I think that adding to the syndromic assessment, an assessment of the immune physiology is perhaps where the promise is for making clear distinctions. And again, recognizing while the technology for this is not universally available, I think as we all recognize its importance, we can maybe begin to make the arguments for trying to find ways to make this fiscally and practically accessible more broadly across the globe. So what does immune profiling look like? I think having accredited and validated assays are critical. This isn't the kind of thing that you're just going to do, in some random lab that just does it as a one-off, once every other year. We need to establish normal ranges for children and not just adults when these labs get rolled out. And I think that to a large extent where groups of physicians like ourselves gathering together today for this symposium are important, and where I wholeheartedly agree where it really does take a village, understanding the interpretation of these labs in the context of the entire presentation is really important. That there, like's been said before, there's never going to be the one single lab that identifies a syndrome or makes the diagnosis or tells you exactly what to do. And so having a team of immunologists, oncologists, rheumatologists, hematologists, neurologists, so on and so forth, is important for their interpretation. And that is, in fact, how we do it at the Children's Hospital of Philadelphia. We have what we call our DIRT team, our dysregulated immunity response team. And it's this multidisciplinary team that includes all of those subspecialties that helps go through all these cases in real time to think about both diagnosis and treatment. So I'm going to talk about a few different kinds of diagnostics that we're making use of today. I'll start with the cytokine panel. So this is a multiplex panel that lets us figure out the sort of qualitative nature of the inflammation. So to not just say our patient is inflamed, but how is our patient inflamed? And again, I appreciate these can be expensive. These can have slow turnaround times. At CHOP, we decided this was so important to us that we actually developed an assay that we can turn around in 8 hours, so we can get same day cytokine information for our patients in the intensive care unit. We're actually in the next 6 months, hopefully going to roll out an assay that lets us turn it around in 1.5 hours, which means we could probably get cytokines now multiple times a day to trend them. And I think that this is a really useful diagnostic tool for trying to figure out what's going on with your patient in real time. So I'm going to give you a case example. This was a young lady that presented to our intensive care unit from an outside hospital with what we thought was HLH, some cytopenias, elevated ferritin. I'll give the punchline now. It turns out that the HLH was actually infection driven due to ehrlichiosis, a tick-borne illness that's present in our part of the country. But as part of her workup and trying to understand her physiology, you've heard about how HLH and MAS are an interferon gamma driven process. And her initial cytokine panel had an interferon gamma of 9,000. I couldn't screen capture that cytokine panel for technical reasons, but I'm showing you the second cytokine panel, which still has a very elevated interferon gamma of 245. Other cytokines were elevated, but not as dramatically as her interferon gamma, given the ranges of the cytokines on our panel. And if you just were to measure inflammation, if you just sent a CRP, yeah, her CRP was high. So we know she's inflamed, but that doesn't tell you what kind of inflammation this child had. Knowing that it's interferon gamma driven allowed us to initiate HLH-directed therapy, in this case with high-dose steroids and low-dose etoposide. And we got traction. You don't need to be a cytokine expert to know that this cytokine panel is better. Her cytokines got better. Now, admittedly, we could have just sent the CRP here, right? Because the CRP is now low, right? So yes, we got traction, we reduced inflammation, but importantly, we can see that the specific flavor inflammation that was important to her physiology, the interferon gamma, made dramatic improvements. Unfortunately, a couple of days later, after this cytokine panel, we went into round, and the ICU tells us that morning that her perfusion is poor. She's her counts are dropping again. She started spiking fevers again. We think she's going back into HLH, and so we want you to give her more etoposide and perhaps intensify her immunosuppression even more. And so we thought that was a possibility, but we considered that the differential diagnosis for a worsening patient is broad and could include a whole bunch of things. And we said, let's just check the cytokines first. So we sent one of our rapid cytokine panels back. And now, again, you don't need to be an expert to know that this looks very different. Now, while the interferon gamma did climb a little bit, the most dramatic increases in her cytokines were in IL-6 and IL-8. And that's a pattern very consistent with gram-negative rod sepsis. And in fact, even more concerningly, the rapid increase in IL-10 in the setting of the high IL-6 and IL-8 makes us concerned for the immunoparalysis phase of gram-negative rod sepsis, because she's making that immunosuppressive cytokine. And again, if you had just sent the CRP, all you would have known was that the CRP was high. Just like it was high in the beginning when she was in HLH, it's high here now subsequently, but for a different reason. And about 5 hours after the cytokines came back, the microbiology lab calls up to tell us, yes, indeed, your patient was growing Pseudomonas in her blood. And so fortunately, we did not increase her HLH therapies once we had this clinical change. Instead, we actually backed off a little bit and broadened her antibiotic coverage, which turned out to be the right thing to do once we learned that, in fact, she was growing gram-negative rods. And so I think this is a really illustrative case where, while the simple tests are useful, right? The CRP does tell you about the state of inflammation. It really shows you the power of being able to profile the nature of that inflammation to know whether it was interferon gamma high or to know whether it was IL-6, IL-8 high, because that puts you in a very different spot of the cytokine storm map and is going to make you consider very different divergent therapeutic choices. Other examples that we started using this for is the MIS-C syndrome after COVID, where we and other groups also found that these patients are relatively elevated in IL-10 and TNF, not to the same degree they showed you in that last patient, but sort of mild to moderate elevations of IL-10 and TNF alpha, and not necessarily such high elevations in interferon gamma. They can be actually widely variable in MIS-C cases. But again, in a patient that is very inflamed and a high cytokine storm, seeing that pattern different from the high interferon gamma pattern or different from the high IL-6 or IL-8 pattern can help you make that MIS-C diagnosis in real time. And so there are a couple of patterns that we think about when we have a high interferon gamma and a moderately high IL-10. That puts us in the HLH-MAS category, and there are a number of papers that suggest that these two cytokines mark those patients. The very high IL-6 and IL-8 marks a bacterial sepsis patient, and the IL-10 and TNF that are intermediately high with an IL-6 and IL-8 that are only low positive and a variable interferon gamma marks the MIS-C patients. And I think the more that we use this, the more we're going to be able to recognize patterns that are going to help us get to a much more specific diagnosis on that map of cytokine storm syndromes and let us pick specific therapies. Some of these other assays were mentioned, and I do think these things are useful in terms of helping you identify where in the spectrum of cytokine storm you are. Soluble IL-2 receptor at the end of the day is really simply a measure of lymphocyte activation, right? So any place where soluble IL-2 is present, it gets cleaved off the surface of these lymphocytes. Anytime you see that in the blood, what you're looking at is lymphocyte activation. So I think it is true then that it is, in fact, very sensitive for HLH, because HLH is fundamentally a problem of lymphocyte activation. Actually, to the point that like we and like Mike Jordan's group and others all sort of agree on this, if you do not have an elevated soluble CD25, you do not have HLH. It is a great rule out test in that regard. If it is normal, you don't have HLH by definition, because HLH is a lymphocyte problem. On the other hand, if it's abnormal, there are a number of things that can cause lymphocyte activation, right? So it can be HLH or MAS, but it could also be viral infection. It could also be leukemia lymphomas, because rapidly dividing leukocytes and those lymphocytes in those settings can give you lymphocyte activation, soluble CD25. So while it is great for the sensitivity aspect of HLH, its specificity aspect is not as great, because anytime you get lymphocyte activation, you're going to get an elevated soluble IL-2 receptor. So I think just bearing that in mind as you're using this test, the context, the whole patient needs, the syndromic aspect of a patient needs to be brought to bear when you're thinking about, how to interpret this test. I think IL-18 is very useful in the setting of our MAS autoinflammatory cytokine storm patients. We know that it is elevated in systemic JA, and in particular, in those systemic JA patients that are predisposed to MAS. So in that setting, it becomes a very useful diagnostic tool to help you say, yes, my patient in that looks like they're in cytokine storm syndrome belongs in this IL-18 high group. That if they have features of systemic JA, really helps sort of nail that diagnosis. And then there are other genetic diseases where you have an IL-18opathy, where you overproduce IL-18, that this becomes an important diagnostic tool as well. So NLRC4 MAS, XIAP, and the other X-linked lymphoproliferative disorders are these high IL-18 conditions where this cytokine can really help you get to the diagnosis. And again, you're going to pick very different therapies if you're in that range, right? So if you're in the high IL-18 group, you're thinking autoinflammatory, that's where you can go after with anakinra, with full confidence that you're getting at the pathophysiology. I mentioned, the genetic syndromes for the hyper IL-18 states. We're not even doing this assay at CHOP, but I think that this is something that is probably likely going to be coming again and becoming more available. So it was sort of worth mentioning that really what you care about when you are thinking about IL-18 is not the total IL-18, but the free bioactive IL-18. And what I mean by that is that IL-18 is endogenously antagonized by the IL-18 binding protein that we all make. This is a very common mechanism amongst all the IL-1 family members. And so really what makes you go into HLH or MAS when you have a high IL-18 is not your total IL-18, But the fact that you're making so much IL-18 that you're overwhelming or outdoing your IL-18 binding protein, and now you've got free IL-18 that is unbound, that can act upon the IL-18 receptor and drive interferon gamma and HLH. And we can actually, it is possible to assay for this. The way that you do this is you capture the free IL-18 by capturing it not with an antibody, but rather with the IL-18 binding protein itself. So when you do this, what happens is that the IL-18 protein that's already, or the IL-18 that's already bound by IL-18 binding protein will not bind to the IL-18 binding protein on your plate. So only the free IL-18 is then bound. And then when you come in and detect that with an antibody, you can actually measure the free IL-18 levels. And when you do this on a research basis, this is really specific for MAS. The only place you ever see free IL-18 are in these autoinflammatory systemic JA MAS patients or NLRC4 MAS patients. And so I think this will hopefully become a more readily available tool to do precision diagnostics. And then finally, some of these assays were also mentioned. By measuring CXCL9, what we can actually measure is not necessarily interferon gamma itself, but the function of interferon gamma in the body, because CXCL9 is an interferon gamma induced protein. So when you see these CXCL9 levels elevated, what you now know is not just is interferon gamma elevated, but your body is sensing that interferon gamma and responding to it in a way that may not be good for you. And then interferon gene signatures to look at type 1 interferon responses is something that's still, again, on the research level, but I think worth mentioning because will hopefully be more available, as time goes on. And again, can be a rapidly turned around test because this is just a PCR diagnostic test, and can help us understand the interferonopathies as part of the cytokine storm syndrome. So this is just to remind us that, we can measure CXCL9 levels. They correlate with interferon gamma in systemic JMAS, and actually differentiate patients that are in MAS from patients that are just in plain old activated or active systemic JA. So being able to measure that interferon gamma access really becomes a useful tool to differentiate your systemic JA patients from patients that are actually in active MAS. So I'd like to offer up one possible treatment paradigm that I, again, appreciate is not necessarily universally available now, but I'm hoping that at least some of the examples that I've shown you might convince you that this is something that we should, as a global community, be working towards, finding ways to make this both financially and pragmatically feasible, because I think this is important for these really vulnerable, critically ill children. If the syndromic appearance and the immune profiling is HLH-like, and what I mean by that is that you've got you've got the cytopenias, you've got the high ferritin, and you can demonstrate that the interferon gamma axis is activated, treat with an appropriate target for that. On the other hand, if the syndromic appearance and the immune profiling is infectious-like, you've got cardiovascular collapse and your IL-6 and IL-8 are high, then I think the most important thing is to back away from aggressive immune suppression, and to provide appropriate source control and give a chance to clear that infection. On the other hand, if despite the fact that your syndromic appearance suggests multi-organ failure, and your patient looks like they might be in a cytokine storm, but the immune profiling suggests that they're not necessarily immune activated, then we should be focusing on a completely different space on the map and focusing on metabolic things or non-immune reasons to be having multi-organ failure. And the way that this gets you to a precision approach is that these are druggable pathways, right? So on the IL-18 side, unfortunately, we don't yet have available drugs. There are drugs that are in the pipeline, IL-18 binding protein, or this bispecific IL-1, IL-18 blocking antibody called MAS825. And I'm pleased to say that the IL-18 binding protein trial in NLRC4 and XAAP actually finished enrollment about 3 weeks ago. Finally enrolled the last patient. So we're hopeful that we will be able to have analyzable data and be able to share that more broadly once that analysis is complete. So it's exciting that may eventually really become a reality for us to be able to block. On the other hand, if you are convinced that you have HLH physiology from your immune profiling, there are a number of places along the pathway that you can target. You can get rid of the CD8 T cells that are a problem using chemotherapeutic agents. And this could be etoposide, this could be cyclophosphamide. There are a number of approaches for that. If you have availability of interferon gamma blocking antibodies, such as emapalumab, and your interferon gamma is high, you can actually treat with emapalumab and block that directly. And we can actually measure that response by measuring cytokine panels and showing that we can bind up all that interferon gamma with emapalumab and drive the interferon gamma level to 0. If you don't have access to emapalumab, you can go downstream in the signaling pathway and block the JAKs that are turned on by interferon gamma using any one of a number of JAK inhibitors, ruxolitinib, baricitinib, tofacitinib, upadacitinib. There are a number of these that are available. Someone had asked about measuring IL-1 levels, and Dr. Cron had responded that these are difficult to measure in blood, and I wholeheartedly agree. So this is the one place where this system fails. I wish it could be that you would measure IL-1 levels and they would be sky high, and that would tell you, yeah, go after IL-1. It doesn't work that way, right? And so we tend to use or really drive on the anakinra side of things when we have an absence of another viable target, right? So if it's not necessarily clear that you are true, HLA interferon gamma driven HLH, but you are clearly in multi-organ failure and in a cytokine storm, and your CRP is high and your immune system is activated, then the absence of the interferon gamma pathway really suggests anakinra as an option, as was mentioned before. Elevated IL-6 levels can suggest IL-6 directed therapies with tocilizumab and siltuximab. Again, I think this is where the syndromic aspect of things comes into play. We tend to go for that more when we feel like our patient is in a Castleman's disease syndromic appearance. So, lots of lymphadenopathy. If you have a lymph node that was biopsied and shows the histologic features of Castleman's disease, and your cytokine panel suggests that IL-6 is elevated, then that really suggests blocking IL-6 as a target. So again, sort of saying this again, when interferon gamma pathways are activated, we use traditional chemotherapy to try and ablate the CD8 T cells. When it's driven by an IL-18opathy, we want to be able to target the IL-18 pathway, even though we don't yet have approved drugs. They are hopefully coming shortly. And then when traditional therapies don't work or aren't desired because of whatever clinical scenario, either direct or indirect neutralization of interferon gamma with emapalumab or JAK inhibitor is the way to go. And then we discuss these other cytokines, IL-1 and IL-6, where we use when we think we're in a cytokine storm syndrome that is more in the autoinflammatory spectrum. Anakinra, as mentioned, is a great drug because of its short half-life. You can get it on really quickly, and you can get it off really quickly if you get into trouble and you think you need to get rid of IL-1 blockade. If you stop it, it's gone within a day. If you realize that IL-1 blockade is helping and you want a longer, more robust blockade, that's when we will often switch to canakinumab. And then we mentioned IL-6 in the setting of cytokine release syndrome and Castleman's disease. So, I'd like to think that this immune profiling approach can be a useful adjunct to, I think, the syndromic approach, which I think is always going to be fraught with the overlap problem. I think having access to an ability to say, yes, the interferon gamma axis is elevated, either by showing high interferon gamma, high IL-10, or showing elevated CXCL9, or showing that your IL-18 levels are highly elevated, helps you really put you in that part of the map that says, yes, go for broke. This is where you really want to go after HLH physiology. And if you don't have these things, again, it doesn't mean your patient's not in cytokine storm. They're just in a different kind of cytokine storm that would maybe make you choose different therapies, or they're in the infectious pattern, which should really make you want to focus on source control. And I think with that, I'll just sort of stop there and see if there are any questions.
Thank you very much, Dr. Behrens, for that wonderful lecture, a comprehensive and really lucid talk, which has taken us beyond the syndromic approach. I think the case example which you presented was quite a clear example of how, if we follow the syndromic approach, we would have probably ended up treating the gram-negative sepsis with more of immunomodulation. So he has given us more food for thought. So we move more towards immune profiling and more of a precision diagnosis, and should not stop short at just the syndromic diagnosis. I think that was a real eye-opener and a wonderful lecture. Thank you very much for that. I do not see any questions either in the panel chat box or, but if there's any questions, I think, yeah. Yeah,
Yes.
please go ahead. Please go ahead.
Okay. Hi, Dr. Edward Burns. Excellent and lucid presentation, very eye-opening one. I'm a pediatric nephrologist. I'm not a rheumatologist. So please pardon me for my ignorance. But I was just thinking, you brought about the importance of interleukin-2 receptor and IL-2 receptor, and in the druggable list, which we can drug. As a transplant nephrologist, we use basiliximab, which is a interleukin-2 receptor antagonist. Very fast acting. We give 2 doses, around 10 to 20 milligram on 0 day, half hour before the transplant, and so we know it acts very fast. Does it have a role when you look at it? Okay, so has it been analyzed, researched in this situation? Does it find?
I wish I could answer that question. I love that question, right? Because I have that exact same question. I've thought that for a decade, right? Like, why doesn't anyone try and study that? Yeah. I mean, so the truth is there's no data, right? So I wish I had the answer. But I think the question is a good one, right? I mean, I think that's exactly the right way to be thinking about this. And, I would argue, where there is at least some data, right, are the calcineurin inhibitors, right? And we certainly use cyclosporin and tacrolimus, and I saw them on other folks' slides, today. To the extent that those things work, I think we should expect that basiliximab would have some activity, right? Yeah. It's hard for me to say like where in the pantheon of things that should fit. But I think it's a really appropriate question that I would love to know the answer to.
I can see Farhan. You have a question or a comment, Farhan? Please go ahead.
Yeah. Hi, sir. I'm Dr. Farhan, pediatric intensivist. I have a question to Dr. Edward as well as Dr. Suchitra Ranjit, madam. She's here, I can see. Madam is part of Surviving Sepsis campaign network also. My question is why cytokine storm and therapies targeting cytokine storm still not part of Surviving Sepsis campaign guideline?
So who are you asking?
Both of you.
The question to. So maybe Dr. Behrens can go first.
Well, listen, I'm not in charge of developing the sepsis guidelines. I will say there are trials that are ongoing, right? That are trying to do exactly this. We actually had a patient that's in our IC right now that we had discussed HLH or not. And they are a little less detailed in the profiling, right? It actually is, and I see Randy's writing in the chat. Actually, some of the things that they're using to stratify patients are ferritin and like CRP, SED rate ratios, these kinds of things, and trying to put them into boxes like this. So I think there are at least some folks that are thinking about it, but certainly let my other colleagues address that, because I think for me that's the future. I think that is the way we should be going.
Madam, because there is not even one word mentioned about cytokine storm in entire Surviving Sepsis.
So the most recent version of the Surviving Sepsis was released in 2020, but most of the articles were up until 2018. So you need to remember that 5 years ago, there wasn't a lot of evidence or even reports on blood purification. I mean, even immunomodulation and cytokine release. Maybe that will change. And after this interesting conference, we have a lot of experts working with bacterial viral infection. So I'm sure things will change, Farhan. And I think many people are working on it, and it's important to write it up and make scientific papers rather than challenging. The guideline task force can only work with evidence. So the ball is actually in your court. If you're convinced, write it up and we can consider it next time.
Thank you.
Chandrika, do we have time for another question? I can see Dr. Suma's hand up.
I think we can take one more question and
Yeah,
then.
okay. So Suma, over to you.
Dr. Behrens, that's a fascinating talk. Actually, I've heard it before and I'd like to hear it again. My question really is, what is the upshot of viral infections? What are you seeing? What kind of cytokine profiles are you seeing in viral infections with HLH? Because one big problem we have in India is dengue fever, which causes HLH.
Yeah. So I'll hopefully have a lot more information for you about dengue in the next year. So I actually have an ongoing collaboration with folks in the Dominican Republic. The first cases of local dengue actually in the US were just reported this week. So this will now become a problem for us. And I'm suspecting more people become interested in it. But there's certainly a lot of dengue in the Caribbean. And I am actually actively collecting specimens from them to do this kind of profiling. I don't have data for you yet, but I will hopefully have data for you in a year. In general, with viral infections, viruses actually do drive interferon gamma. So you will see elevated interferon gamma in viral infection. HSV is a great example. We've had kids with HSV infections, systemic, with elevated interferon gammas. Not as high as we see in HLH. So again, that's where sort of trying to figure out where all these cutoffs belong are going to be important. But what we don't see, what I would say is that when it is just like sort of run-of-the-mill virus, that's where, again, it's this contextual interpretation. You have less of the syndromic features of HLH. You have less of the cytopenias and other things. So I think it's putting together the immune profiling with the more traditional, syndromic profiling that we've all been doing, which is what's going to get us to help put patients in the right box.
Can I have a quick word about this, Jayashree? Do we have time? Because we just got a paper accepted in PCCM on hyperferritinemia and dengue. So maybe I'll take 30 seconds or not. I'm happy to keep
Am I
quiet.
allowed, Chandrika? Because I think we have overshot time. I mean, it's up to Chandrika.
Yeah, please go ahead, ma'am.
Okay, go ahead.
Okay. Thank you, Chandrika and Jayashree. So we just got this. It's an observational study, unfortunately, 55 children with severe dengue, severe enough to require intensive care. They were in shock, they were bleeding, they had organ dysfunction. The most prominent was liver and very high ferritin. So what I'm going to take my few seconds to say is that sometimes, just to argue on the other side of the coin, we have very, very impressive ferritin elevations. 24 out of the 56 were over 10K, and including 2 over 100,000. So in the acute phase, provided they came early and we gave supportive therapy, which is appropriate, all of those markers came right down and they improved. Only in 3 who came late and were bleeding, they weren't behaving according to the typical temporal syndromic trajectory. We needed to give immunotherapy. So that's all from my side.
Thanks, Suchitra. Thank you very much, Dr. Behrens. There is a question in the chat box. I would request you to please answer that, because obviously in a resource limited setting where the labs are not available for a complete immune profiling, there is a question about whether there could be certain indirect surrogates about interferon gamma axis activation. So if you have time, you could just kind of answer that question. So over to you, Chandrika, for the next co-chair to take over for the next talk. Thank you very much.
Thank you, ma'am. And thank you, Dr. Behrens, for your talk. I now request Dr. Suchitra Ranjit to please introduce our next speaker, Dr. Gabriela Bottari.
Thank you for this kind invitation. I share my screen.
It's my pleasure to introduce the next speaker, Dr. Gabriela Bottari. She's from Children's Hospital Bambino Gesù. Apologies if the pronunciation is wrong. This is in Rome. And she's done her clinical fellowship in intensive care medicine and also trained in pediatric anesthesiology. Her special interests are in extracorporeal blood purification, and she's the section chair of the Italian Working Group on Continuous Pediatric RRT, section chair of the Italian Working Group on cytosorbent therapy, and has got several publications and presentations on blood purification, CRRT, extracorporeal therapies. So she's well suited to give her next talk, and we look forward to learning from Dr. Bhattari. That's it for me. Thank you. Welcome.
Thank you for this lecture. Extracorporeal blood purification and cytokine storm syndrome is one of my favorite talk. And as introduced by previous speaker, cytokine storm syndrome is a very complex clinical condition with a wide range of clinical and laboratory abnormalities, and however, many underlying diseases can lead to this so complex clinical condition that also pediatric intensivists have to manage and to fight with the complication. In fact, cytokine storm syndrome can lead to a life-threatening condition, finally to multi-organ failure and death. For this reason, many authors in the last decade have discussed about the potential benefit of blood purification in this clinical context. And many theories have been suggested how the potential role of blood purification in cytokine storm. The most important theory, and also the most important, most common theory, is by Professor Ronco, the theory of cutting the peak. Through blood purification, we are able to reduce the high level of cytokine in the blood compartment, and so is more easy to achieve an immune homeostasis. Honoré and Matson later postulated that this positive effect could be related to a balance between the tissue compartment and the blood compartment with the threshold modulation, and Di Carlo later added some issue discussing how the high doses of hemofiltration could help to remove with the lymph drainage cytokine from the tissue compartment. Finally, Peng, with a more complex therapy, postulated that blood purification can help in immunomodulation with a mechanism of reprogramming the activated leukocytes, in particular the activated monocyte and lymphocyte. Each of these theory has a common point, a key point in common, that is the potential role of blood purification in immunomodulation, both in pro-inflammatory and anti-inflammatory reaction, without a selective and a definitive cytokine blockade. And that could be also a very useful approach when a clinician, and it is very common, are not so sure about the underlying trigger of cytokine storm. We have in the previous talk discussed about the infection control, but sometimes it's not so granted if the cytokine storm is led by an infection or another immune mechanism. And so blood purification in a life-threatening condition can help to improve organ function without induce a selective cytokine pattern blockade and an immunosuppressive approach. So in the last years, the concept in pediatric care, intensive care in general, moved from the concept of the single organ support to the concept of the extracorporeal organ support. That is something that embraces the removal removal of mediator that can lead to the organ damage, to improve the coagulation disorder associated finally responsible of microthrombosis and organ damage, and in the same time with different type of device to support the different organ and system. And COVID-19 was an important lesson in intensive care to learn about this concept. In fact, this was a potential reason of cytokine storm to associated to this type of viral infection, and clinicians have fighted with many complications related to a cytokine storm syndrome, such the microthrombosis related to COVID-19, the epithelial damage, the capillary leaks, and the crosstalk between organ and system very often responsible of the multi-organ failure associated to this severe infection. Also in pediatric clinical care, we have had some guidelines about the opportunity in COVID-19 severe infection in pediatric critical care to start very early with a CKRT approach to prevent and to avoid a progression in AKI associated to COVID-19 infection for the cytokine storm pattern associated. And for the first time, this recommendation suggested also the use of other type of device than the CKRT, for example, absorbing coron or some hemofilter with an enhanced absorption capacity as the OX-series. Talking about the potential technique that pediatric intensivists can use in cytokine storm syndrome, historically we can find three types of techniques: hemofiltration, hemabsorption, and plasmapheresis. About hemofiltration, that is in intensive care for the major stability of a continuous therapy, the CKRT, the most important randomized control trial in adult population, but also some important study in pediatric critical care have suggested that improving the doses of the dialysis is not able to improve organ perfusion and survival and hemodynamic stability. And so in the last year, the DIGO recommendation don't suggest to improve dialysis doses over 55 to 40 milliliter per kilogram hours. Therapeutic plasma exchange, on the other hand, is one of the most known and the most proven blood purification approach in cytokine storm syndrome. What is important is to know that the therapeutic plasma exchange can be used in the right way in this context, or that is that we have to know the kinetics of the mediator removal. That is not only based on the exchange volume, but also on the frequency of the session. And this is one of the most important studies related to the impact of therapeutic plasma exchange in thrombocytopenia associated to multiple organ failure by Frank Guyen. He showed as therapeutic plasma exchange can help to manage the microthrombosis that lead to multi-organ failure related to high level of Willebrand factor, and he, as you can say, published different studies showing that we can improve organ function and survival treating patients with this therapeutic extracorporeal approach. It's very important to know when we use a therapeutic plasma exchange is that we have to know that we have centrifugal plasma exchange and the membrane plasma exchange. And in particular, when we use this approach for thrombocytopenia associated to multiple organ failure, our mediator target is von Willebrand factor that are very large mediator, more than 1,000 kilodalton. And the cutoff of the membrane therapeutic plasma exchange is 1,000 kilodalton. So the most suitable approach is to use the centrifugal therapeutic plasma exchange. Not only, it's very important to repeat the session along the time, because von Willebrand factor require hours today to move from the tissue compartment in the blood compartment of the first session. And so it's very important to follow a schema to maintain the therapeutic effects along the time. The other important device that emerged in the last year are the absorbing columns. These are devices that are made in biocompatible resin with a very huge surface. This type of devices work by absorption, are not hemofilters, so not for convection, not for diffusion, but only by absorption. And the mechanism of action are based on size exclusion effect, because the target molecule are the medium molecular weight molecules, and this type of device work also by interaction with hydrophobic interaction and ionic interaction, depending on the type of the column. Cytosorb is one of the most known columns. Many studies in the last year have published, also in pediatric critical case, is made in copolymer beads, and the target molecules, molecular weight are between 5 and 60 kilodalton. The mechanism of action is also concentration dependent. That means that higher the concentration of the mediator, high in the blood compartment, higher the removal. And this type of device is very feasible. We can use this type of device in single hemoperfusion, in combination with CKRTs, in pre-hemofilter and post-hemofilter position, in combination with the extracorporeal membrane oxygenation, and during cardiac bypass. Now I would like to show you some clinical experience about the use of hemoperfusion as extracorporeal blood purification pediatric critical care in cytokine storm syndrome. This first one was a clinical case published in 2019 about a young boy with cytokine storm syndrome after therapy with chimeric antigen cell. He was treated for a refractory B leukemia, and 7 days after the advanced immunotherapy, he developed a CRS characterized by an acute respiratory distress syndrome with the need of PICU admission and invasive mechanical ventilation. In this clinical context, we have decided to treat the boy not only with a supportive therapy, but also with a blood purification approach based on hemoperfusion in combination with CKRT. The cartridge was changed in the first day every 12 hours to fight better the cytokine storm in the clinical context, and then we have continued with the hemoperfusion therapy for 96 hours, a total of 4 days. We have observed in this clinical case not only a significant reduction of most important biomarkers, interferon gamma, IL-10, IL-6, and ferritin, that reduced bedside in association to also an important improvement of the chest X-ray, and in less than 10 days we were able to wean the boy by the invasive mechanical ventilation, and on day 19 he was discharged by PICU. And in this occasion, with this clinical case, we have observed how the hemoperfusion with this type of colon could be a useful therapy. It can be used together with tocilizumab without interfere in the effect, because the cutoff for tocilizumab is more than 100 kilodalton. It helps with a faster improve in the organ damage associated to the cytokine storm syndrome, and at the same time we are able in this way to modulate the effect of the chimeric antigen cell without completely switch off this type of therapy. That's an important effect for the underlying malignancy. Another clinical case that I would like to show you that is unpublished is of a 12-year-old boy that developed cytokine release syndrome after blinatumomab and other type of advanced therapy that can induce CRS. In this case, the boys developed not only an acute respiratory distress syndrome, but also a refractory shock and an ATA. We have applied the same schema of the therapy with CAR-T in combination with hemoperfusion. We have observed a dramatic improvement in the vaso-inotropic score. These are the graph of the trend of the biomarker of inflammation. As you can see, it's very important to continue the therapy for at least 3-4 days, because we can observe some resurge of the cytokine peaks along the time. And also another important parameter, that is the extra lung water index related to the inflammatory edema in the lungs, improved during the therapy. And these are also the microcirculation. I like this type of technique to monitor the organ perfusion. These are the videos of the sublingual microcirculation in the boys. This is from the start of the therapy. You can see different area during the treatment of vessel that is stopped. This is a typical partner of important organ damage that we call heterogeneity in microcirculation. And after the treatment, we had a good improvement also in the microcirculation, that is a good mirror of the organ perfusion. Sorry. Okay. No, just a moment. I have. Okay, with this clinical experience, we were able to understand that it's very important important to change the sorbent more often in the first 24 hours, every 12 or 8 hours, in order to achieve a strong reduction of the cytokine peaks, and then to continue the hemoperfusion for 3-4 days to prevent new peaks related to also an impact in the clinical setting, and that this type of therapy can be used safely also with other type of immunomodulation therapy such as tocilizumab. And I would like to share with you that this type of schema of therapy was also used and suggested by the FDA during the last pandemic for cytokine storm syndrome associated to COVID-19. Another important setting that you have discussed a lot in the previous talks is the hemophagocytic line for histiocytosis. We have treated with hemperfusion in combination with the CKRT, also children with this type of clinical picture, and we have observed important results in secondary form of HLH with an actual mortality observed of 33 in comparison to the expected mortality of 47% in our cohort. And also in these studies of 6 critical ill children with multi-organ failure associated to HLH, treating the patient with this extracorporeal blood purification approach, we have observed significant reduction of bedside biomarkers of inflammation. Multisystem inflammatory syndrome is another cytokine storm syndrome that we have learned in the last pandemic is characterized by an high tropism for the cardiovascular syndrome with the need of vasoactive therapy in 63% of cases, and the incidence of extracorporeal membrane oxygenation is between 4 and 6% of cases. Also, in this clinical context, as cytokine storm syndrome, we have proved a potential benefit of blood purification. This is the case of a 14 years old girl. She, after asymptomatic COVID-19 infection, developed an EC characterized by myocardial dysfunction with an ejection fraction of 35%. We have approached this girl with the same therapy, with the same schema that I have showed you, and we have observed an improvement in 72 hours of the ejection fraction, reduction of biomarker inflammation, including ferritin, and also an important reduction of vasopressor inotropic drug. Almost in the same time, this type of results were observed also by the team of Valdebron Hospital in Barcelona of Ricard Ferrer. They have treated a similar clinical case of a boy with a history of fever and dyspnea for an infection of COVID-19 who developed myocardial dysfunction, 30% of ejection fraction associated to acute respiratory syndrome. And also in this case, the approach based on CKRT and hemoperfusion with Cytokine was very useful in support for a faster improvement of the patient. About the MIS-C, what we have learned is that can help to potentially spare the need of ECMO, or can help in synergy with extracorporeal membrane stimulation, treating also the inflammation induced by the ECMO himself. And also in this case, we can use in a safe way the hemoperfusion in synergy with other immunotherapies. In conclusion, of course, also in intensive care, it's time to talk about blood purification as a potential real immunomodulation therapy. We have moved also in this setting from an approach based on the big data and randomized control trial to a more personalized approach to choose the right patient in the right time to achieve the most important result, also with this type of therapies that can help clinicians to manage patients in life-threatening conditions associated to cytokine storm syndrome. I concluded, and thank you for your attention.
So thank you very much, Dr. Bottari. That was a very comprehensive talk with a lot of practical points on how often and the filters need to be changed and the application in various modalities. So that was very impressive talk with a lot of learning points. Congratulations. And any questions from anybody? Maybe you'll have a look at the chat.
Can I ask a question?
Yep.
So, did you have any neurological complications post Plex or cytosol? Did any one of them develop cerebral edema or a CNS event during these procedures?
Really, no. Patients had any neurologic complication. What instead I would like to say that the impression is that D-dimers and microthrombosis improve very well with this type of therapy, because on one hand one can think that using an extracorporeal device you can worsen the coagulation microthrombosis. But the clinical experience now, we have treated a lot of patients with this type of technique, and that D-dimers and coagulation disorder associated to this cytokine storm syndrome improve the fast. In fact, one of my future potential evaluation would be on this topic, the impact on microthrombosis and D-dimers and coagulation disorder of this technique.
Can I ask one question?
Yeah.
Thank you. It was lucid presentation, Dr. Bottari. Of late in our intensive care unit, I'm a pediatric nephrologist. Just to, I team up with our Dr. Akshay and Dr. Chandrika to plan the extracorporeal therapies. So we also end up using a lot about this Oxiris filter, right?
Sorry?
Oxiris, O-X.
Oxiris, yes, of course. Oxiris is another good solution because you have an hemofilter, so convection diffusion with enhanced absorptive capacity, and so it can be used also. Of course, for physical reason, the surface is less than an absorbing column, because absorbing column show huge surface. We talk about 40,000 square meters of surface. Instead, an hemofilter also with enhanced absorption capacity has less surface, but it can be used for also as a bridge. Sometimes sometimes we use cytosob as in combination with the standard hemofilter as attack therapy, and then if we are not enough satisfied, we move to the oxygen to maintain in simple CTRT, because we have oxygen that is also an hemofilter.
Okay, so how do you decide in your unit which one to start with, or do you have a protocol to always begin with cytosob and then move ahead to Oxris, or how do you take a decision?
Yes, we have a protocol related to the use about the weight of the patient, because of course these devices are designed unfortunately for adults. So we have to manage the situation in a safe way. And now in this moment in Children's Hospital Bambino Gesù, we apply cytosob only in children weighing more than 10 kilograms. We applied this type of device in children less than this weight only if they are supported in extracorporeal membrane oxygenation. And so this is a safety protocol. About the clinical indication, we try to look at the clinical setting, and we have of course for septic shock we decide on the basis of the vasotropy inotropic score, on the multiple organ failure associated, but also on mediator of inflammation. We use CRP, ferritin, procalcitonin, and IL-6 bedside to decide in combination of with the clinical features.
I think it also would mandate upon the, it will be decided more along with this, the hemodynamic condition of the child. Septic shock, very, very unstable. We want to do a priority. You can go ahead with Oxyris. And if it is a plain cytokine release, like we were talking about the cases, like leukemia cases, there we can directly go ahead with the cytosob, where we don't need the convective currents, right? If we want to join our convection to along with the adsorption, then an Oxyris would be useful in a hemodynamically unstable child, right? I hope.
Yes, for the hemodynamic, when children are very unstable, I have to say that our first choice is the hemoperfusion, because we have dramatic result, in terrific result. We usually also with the vasoinotropic score more than 40, 70 points of this, we are able to switch off vasoactive drug usually by 72, 96 hours.
Mm-hmm. Mm-hmm.
So it's a very, very strong efficacy.
Yeah, I think in the interest of time, we'll wrap up this session and move on to the case discussion. So thank you, Dr. Botari, for your lecture, and thank you, Dr. Suchitra Ranjit, for chairing the session.
Thank you.
Over to Dr. Somil to introduce our experts and the moderator for the case discussion. Thank you.
So thank you so much. Because I just got lost. I just became an audience to these wonderful lectures, and let me come back to my duties. Thanks, Dr. Chandrika, for reminding me. And now I'm going to introduce for the next session two eminent speakers, Dr. Randy Cron, who is the director of pediatric rheumatology placed at University of Alabama at Birmingham. And he has completed his PhD in immunology from University of Chicago, and currently his lab, which is a research lab, focuses on the heterozygous mutations in familial HLH genes and in contributing to cytokine storm syndrome. So I welcome Dr. Randy for this session, and I would also like to welcome Dr. Timothy Cornell,
And Dr. Connell is a professor of pediatric critical care medicine at Stanford, and is also the professor of pediatrics at Stanford only, Palo Alto, California. And his research interests are the role of epigenetics in regulation of inflammation, precision medicine for targeted therapy in critically ill children, and molecular biomarkers in pediatric systemic inflammatory response and sepsis, and their use in precision medicine. So bringing their wealth of experience and knowledge, I welcome you all on this platform. Welcome Dr. Timothy and Dr. Randy once again. Right. And I would invite Dr. Farhan. Dr. Farhan Sheikh is going to be the moderator of this session. And he's a pediatric intensivist at Rainbow Children's Hospital, Bangalore. And over to you, Dr. Farhan.
Good evening, everybody. I'm Dr. Farhan, pediatric intensivist at Rainbow Children's Hospital, Hyderabad. We are going to start with a case presentation. Dr. Monica, who is the fellow in the DRNB Pediatric Critical Care, which is a super specialty in pediatric critical care. And she's a second-year student in that. She's going to make a case presentation of a septic shock child with the cytokine storm. And we have some interesting questions, and I would like to discuss at the end of the presentation.
So Monica, please go ahead.
Yes, good evening, one and all. Firstly, I would like to thank the organizers for giving me this opportunity to present. We are going to discuss a child with sepsis, multi-organ dysfunction with cytokine storm. This is a 9-month-old child who presented with complaints of loose stools since 2 days, fever since 1 day, and rapid breathing and lethargy for 1 day. This child is born out birth history and past history are non-contributory. For the above complaints, child is brought to our emergency room for further management. At presentation, child was sick looking, had acidotic breathing and poor perfusion. The initial physiological categorization, the child is unstable and with life-threatening condition. Airway was maintained with position. There was increased respiratory efforts. There was rapid breathing with the saturation of 88 on room air and 100% on NRM. Child was tachycardic. There was hypertension with poor perfusion, and GCS was 10/15, and there was hypoglycemia, and the child was febrile. Final physiological categorization, the child was unstable with respiratory distress due to acidotic breathing and in hypotensive shock. Management done in ER, child presented with hypoglycemia and hypotensive shock with metabolic acidosis and hyperlactatemia. We had started the child on NRM, gave 10% dextrose bolus and a crystalloid bolus, and shifted the child to PICU. On arrival to the PICU, a child had metabolic acidosis, shock, and altered sensorium, for which the child was intubated, and blood investigations were sent, and first dose of antibiotic was given. IG line was placed in view of shock, and due to poor hemodynamics despite adequate fluid resuscitation, child was started on inotropic support. For the next 2 hours, child required stiff inotropic support. For later, stress dose of hydrocortisone was given in view of catecholamine refractory shock. Due to the persistence of shock, despite stiff inotropic support and stress dose hydrocortisone, we have planned for exchange transfusion, suspecting underlying gram-negative sepsis with cytokine storm. Gradually, there was also transaminitis and coagulopathy with large lower GI bleed and thrombocytopenia, for which child required transfusions. By the end of 12 hours, there was gradual oliguria requiring peritoneal dialysis. At the end of by the end of the first day, that metabolic acidosis was improving, and the VIS score also came down, but child persisted to have fever spikes with poor perfusion. IVIG was given in view of cytokine storm as a part of immunomodulation. There were ongoing fever spikes. Child was started on broad spectrum antibiotics. PCT was 243 and CRP was 41. On day 2, although there was transaminitis and moderate coagulopathy, metabolic acidosis was improving without needing CRRT. Urine output was also improving and peritoneal dialysis was continued. Fever was persisting on day 2, and second dose of IVIG was administered as a part of immunomodulation. On day 3, child was continued on mechanical ventilation. His hemodynamics improved. Transaminitis and coagulopathy stabilized. Metabolic acidosis was getting better, but the child had left focal seizures for which CT was done, which showed bilateral cerebral frontoparietal and cerebellar hypodensities, which are suggestive of vasculitis due to pneumococcus. On day 2, we have got the culture reports, which showed pneumococcus, and antibiotics were optimized accordingly. On day 4 to 5, child had altered GI aspirate with hypoalbuminemia, with the rest of the issues settling. His hemodynamics stabilized, metabolic acidosis was improving, his kidneys opened up, there was urine output, and there was also transaminitis and coagulopathy was also settling. And the fever spikes also settled by day 5. By day 6 to 9, there was improvement in his hemodynamics, and we were able to stop ionotropes, and we were able to extubate him to HFNC. There was improvement in the urine output with and the hepatobiliary function, and coagulopathy is also becoming better. Child was initially started on cyclic feeds, trophic feeds, which were gradually increased to attain the full feeds. There were no fever spikes, and hematologically there was thrombocytopenia requiring transfusion. And then from day 10 to 14, child was afebrile, sensorium improved, his hemodynamics stabilized, he was maintaining saturations in room air, renal and hepatic functions improved, oromotor stimulation and physiotherapy was started as a part of rehabilitation, and child was shifted to ward on day 14 after 2 weeks of ICU stay. These are all the labs. When the child was improving, there was a stabilization in his hemoglobin, platelet count was improving, and PCT has also come down. Renal functions were also better. This is a video of the child post resuscitation. When the child was shifted to ward, he was accepting feeds orally on very low flow, which was gradually tapered, and the child was stable on room air. Course in the ward from day 15 to day 22, child started having low-grade fever spikes, and workup for fever was negative. Child was antibiotics were continued. Despite these antibiotics, child continued to spike high-grade fevers. So initially, antibiotic fever was considered, and antibiotics were stopped, and cultures were sent, which all turned out to be sterile. Hemodynamics was stable on room air. Child was on full feeds orally even in the ward, and urine output was also adequate. After shifting to ward, initially it started with low-grade fever spikes on day 15, day 1 of ward stay. Then gradually the fever spikes turned out to be high-grade, 103, 102.3, and 104 also by day 20. The child started having fever spikes from day 15 of admission after a febrile period of 10 days. There was also gradually raising inflammatory markers. There was no localizing signs of fever. Urine culture was sterile, and all blood cultures were sterile. Gastric aspirate for AFP was also negative. As a part of workup for pyrexia of unknown origin, CSF studies were done, which were normal, and bone marrow studies were also normal. Ultrasound abdomen echo was normal. Chest X-ray was showing non-specific shadows. In view of this high-grade fever spikes and dull activity, child was shifted back to PICU. After shifting back, child had continuous fever spikes, temperature not touching the baseline. On day 22, day 23, day 24. These are the lab trends. When the child started having fever, there was an increase in the platelet count. PCT was raising, CRPSR was raising, and ferritin was also raising. This is the timeline for initially for 2 weeks, child was in PICU. There was fever for 4 days, where child received IVIG 2 gram per kg as a part of immunomodulation. And then day 15 to day 22, that is the 3rd week of his hospital stay. Fever was present from the 3rd week again. And we have done all the infective workup, which have turned out to be negative in view of any autoinflammatory condition. It was started on methylprednisolone 1 mg per kg after doing bone marrow studies, which were negative. On day 23, due to persistent fever spikes and dull activity, child was shifted back to PICU, and we have given IVIG and anakinra on day 24, as there was persistent fever spikes, raising inflammatory markers and ferritin. Day 25, that is after 2nd dose of anakinra, fever spikes came down. The child continued to receive anakinra in view of persistently elevated ferritin. These are all the lab trends. Initially, this is a point where we have given IV anakinra. Post that, fever settled, but ferritin continued to rise. Ferritin and CRP also. These are the fever spikes which were touching the baseline in between the spikes after anakinra. And this is day 26, that is day 3 post anakinra, where the child didn't have fever. There is only 1 low-grade fever spike. Even after anakinra, on day 24, child continued to have elevated ferritin and other inflammatory markers like CRP, but his renal and liver functions were normal. Thereafter, after anakinra, his fever spikes came down, but child developed respiratory distress, shock, and encephalopathy with increasing ferritin levels. Chest X-ray showed some fluffy shadows, which was suggestive of infection. Child was planned for intubation and mechanical ventilation, but parents opted for non-escalation of treatment. Child was continued on HFNC, inotropes, and antibiotics, and despite these, child succumbed to death after 26 days of hospital stay.
That was a very nice presentation, Dr. Monica. So as we can see here, this child came in a very stormy presentation with very bad septic shock and resisted it aggressively. And within first 12 hours of admission, child received a broad spectrum antibiotic cover, inotropes, steroids, stress dose of hydrocortisone, IV immunoglobulin, plasma exchange was also done. And by day 3, fever settled down. Next day, we came to know that it was a pneumococcal sepsis, and we were anyway covering it with antibiotics, and child settled down. And from day 5, day 6 onwards, things were fine, and the child remained afebrile for a period of 10 to 12 days, and a new onset fever started. And then, as we all saw, what happened. So the first question is, was the child in cytokine storm in the first 24 hours of presentation with high-grade fever, shock, and MODS, where we gave IVIG steroids in exchange transfusion? Obviously, it looks like that. And this child would have benefited if we would have started this child on anakinra. This child being just 9 months old, we have actually used cytosorb in even a smaller child of 8-month-old child. Also, we have used cytosorb in the past with a blood flow of just 40 ml per hour. But was this a candidate for this kind of interventions initially? And if we would have used anakinra earlier in the first episode, or something more aggressive like CRRT with cytosorb or auxiliaries, could we have prevented the second episode of cytokine storm? That is my first question to the experts.
So I'm happy to weigh in from the critical care perspective. So I need to reset the whole concept, because saying cytokine storm is simply a symptom of the disease. It's not the disease itself. And I think that's a really important distinguishing characteristic here. You know, if you go all the way back to 25 years ago with the very first anti-TNF trials in sepsis, the concept there was to block cytokines and to especially TNF alpha, because of all the animal data. And the very first studies actually showed benefit in the small pilot studies. What we subsequently learned from that is we actually ended up causing mortality in some patients. And so what that tells me is that this immune response is necessary. It absolutely has to happen. It's the steroid story, right? If we give steroids too long, too much, too early, we actually end up creating mortality. And some great data presented here. And I'm a fan of immune modulation. I'm a fan of extracorporeal therapies, and I do use them. But we have to realize we're using them to control the symptoms. We don't have the source of what's causing the dysregulation. And in fact, in this case, the use of IVIG in sepsis is probably, is the only immune modulatory therapy that has been shown to improve mortality. So I think the use of IVIG, as I put this kid together, had pneumococcal sepsis, which resulted in a dysregulated immune response that we see as cytokine storm. I think the IVIG was absolutely a great move here, along with the antibiotics. It seems to me that through that course and the first ICU admission, you guys got way out in front of the etiology for that. You changed the course of the pneumococcal sepsis. And unfortunately, then this child had a second flare. And so now in those kids, when I see that, I start going back to, wait, what is causing the dysregulated immune response here? And did it contribute to the initial trigger, which was the pneumococcal sepsis? As I see ferritins continue to rise, I always worry that we've got smoldering underlying inflammatory response going on that we're not in control of. And then it gets really hard and kind of tricky. Do you do etoposide? Do you do steroids? You know, what else are you going to do? And I think that's when you really pull your consultants in and start to have the discussion. It's, in my opinion, it's not the cytokine storm at that point. As long as I have hemodynamic stability, as long as I can keep my oxygen delivery at an adequate level, that I'm not building up lactates and the other metabolic processes are okay, I tend to stay there, obviously cover, common things with low risk therapies, cover with antibiotics. Steroids are a plus minus sometimes, but I always come back to what is causing my immune dysregulation that is leading to this syndrome of cytokine storm. So that's my short answer. Happy to answer other questions on that or around that.
Yes. In this particular case, after 10-12 days of febrile period, when the child started fever again, even I was feeling the same thing. So we were not immediately, jumping to the diagnosis of cytokine storm right away. Just 7 days, we tried to rule out everything else. We stopped all the antibiotics because the child was on day 16, day 17 of antibiotics. So we thought of first antibiotic-induced fever. So we stopped all antibiotics and gave a period of 48 hours without antibiotic, but 104, 105 was going on. We sent all types of cultures, urine, blood. Every day we were sending 2 sets of cultures. We did a CSF, we did bone marrow culture. Nothing was going from anywhere. Then we started 1 mg per kg of methylprednisolone, hoping that maybe it is just an autoinflammatory, autoimmune process and it will settle down. It did not. And then ferritin was just going up and up. But 2 cell lines were not down. The WBC counts and platelets were normal. Only hemoglobin was falling. That was one thing. So then we had a discussion with Dr. Chandrika, and then we thought we should start anakinra. My question was, can a patient have 2 cytokine storm in one admission? First thing. And yes. My second question was, if this second episode of deterioration, was it an immune paralysis? And if it was an immune paralysis, was the decision of giving anakinra right decision? Because then it would have blocked IL-1, causing more harm.
Yeah, Absolutely great question. So can they have more than one cytokine storm in a hospitalization? Absolutely. I've seen it multiple times. And again, as I was following the case, this is the exact pattern and the exact process I think we would have done with this child in our hospital as well. You get on top of the primary issue that's there, which was pneumococcal sepsis. You got through that. Whether it again was this second round immune paralysis is a great question. What we don't know, what we don't see in true immune paralysis is that cytokine storm component of it, where we see fevers, where we see big large escalations in things like ferritin and those components. However, could have the immune paralysis led to a second trigger that then created the dysregulated cytokine storm? That is possible. And again, I don't think we understand enough about these different phenotypes and how you shift from one phenotype into the next to answer that question with a high degree of certainty. I think it's very reasonable. Again, you looked at, you had bone marrow results, you had other culture results. None of those were showing a primary cause or the source control for the immune dysregulation. And then I think it's reasonable to say, well, let's try some anakinra. The nice thing about anakinra versus tocilizumab, it's short-lived. So if they do need to mount an inflammatory response, it's not quite that duration that you're going to see. Could have you done other extracorporeal therapies? Should have you done cytazorb or one of those? In this second round, the first round you got better. So in my mind, let the body do its thing. In the second round, it didn't seem like you were quite to that big hemodynamic compromise. You weren't on vasopressors. I usually leave those therapies until I'm really at that point, because I know all I'm doing is treating a symptom. And so then it comes back to what's causing my immune dysregulation and how do I treat that as a source? Initially, it was infection. The one question I had, was there ever hepatosplenomegaly in this kid?
Sorry, sir. What did you say, sir? Can you repeat? Hello?
He was asking if the liver and spleen were enlarged.
Yeah. Was the liver and spleen enlarged?
Yes, there was a mild to moderate hepatomegaly.
Yeah. Again, I think it's and again, this is the point. That the first kind of episode of the cytokine storm, that's, to me, that looks straightforward sepsis. I think, again, treated exactly the way it should be treated. Child got through it, but now they've come back, and that's the point I pull my consultants in and say, help here, because this seems to be the underlying issue here seems to be in a realm of immunology, rheumatology. And so especially if I start seeing things like hepatosplenomegaly or elevated fevers, elevated inflammatory components without hemodynamic compromise, that to me says the biology is under there, and that's what's driving the cytokine storm. I'd pull my colleague in and Dr. Cron and see if he had thoughts about that second episode or how he might have advised us any differently.
Yeah, I mean, this kid clearly was sick from pneumococcus. My daughter had it when she was about 2, but she didn't end up in the hospital, and antibiotics helped her. and probably ultimately help this child as well. But the kid was clearly sicker. And that, this is where I kind of live. Why are some kids who get the same organisms much sicker? And there may be path specific or load specific or something, but I think a lot of times it's just we have different host immune responses for whatever reason that some kids get much sicker. My guess is our intensive care unit colleagues would not have called us in rheumatology in the first day or two, because this looks like sepsis, which it was. And so we probably wouldn't have got involved. Just anecdotally, and this isn't so much sepsis, but just kind of cytokine storms in general. I haven't found intravenous immunoglobulin helpful in general. It's definitely, for the most part, likely not harmful, but I haven't found it all that helpful. But in general, and I think I've told you this before, I'm very fast to go to anakinra because the benefit to side effect ratio, at least in my experience, is very high. And if it's not going to help with it, within 48 hours. So if they're really tanking, then we may have to go to high dose steroids in addition. But you can get away a lot of times with just using anakinra to see if it helps. And usually, within 48 hours if it is, and if it's not, then you kind of reevaluate and rethink what you're doing. The second episode, had certainly some features of cytokine storm, but not others. And I don't know if this child got a fungal infection or a secondary infection, or if this was all the cytokine storm that resulted in the child's demise. But that would be the one place where if I'm worried about a fungus, I may not want to use anakinra. But again, you have to weigh that against how much of it is the hyperactive immune response. So I don't know if I clarified much. This was an unfortunate case, obviously, and if my ICU colleagues did call me early, I probably, if this child was clearly very sick, very quickly, and so I would have had a very low threshold to starting anakinra much earlier.
Okay. What about this second phase? How to identify? Because myself and Dr. Chandrika had a discussion. I was saying that it can be immune paralysis, and Dr. Chandrika was saying that if it is immune paralysis, CRP will not be high and ferritin will not be high. So how to identify immune paralysis? In immune paralysis, will the CRP be low or ferritin will be lower? How do you identify IL-10 storm?
Now, immune paralysis is a specific diagnosis of monocyte deactivation. So truly, the key to diagnosing immune paralysis is flow cytometry and percent of HLA-DR expressing monocytes. You can do a whole blood assay, but that's not standardized. So, and you will see, you can see IL-10 be elevated, although we also know you can see IL-10 as an anti-inflammatory mediator also be elevated along with IL-6, IL-1. So your pro-inflammatory mediators can be elevated along with IL-10. It's a hard diagnosis to really nail down, there's no easy quick way to diagnose immune paralysis from a laboratory perspective. I have seen situations where ferritin's been up, CRP's been elevated, and IL-10 has been sky high. We've tested, we've done flow cytometry and we see low monocyte deactivation. Now, is that monocyte deactivation and immune paralysis, and now you've got a secondary infection, and it's that secondary trigger that has led to the pro-inflammatory state and the increased ferritin and the increased CRP? Potentially that is a story there. Yeah, again, going back to when do you immune modulate and how do we immune modulate? I really worry about our specific immune modulations without knowing which phenotype we're in. I think of all the anti-cytokine therapies that are out there, I go to anakinra first, mainly because you know rather quickly and it doesn't hang around that long. But again, I go back to the original anti-TNF data. You know, the study data from the early studies of anti-TNF and sepsis were very, very impressive data. Ultimately, when we took those to multi-center studies, we actually ended up doing harm. And so I worry about this immune modulation. Now, the one thing we do have, and we've got some data that is pretty safe, especially in thrombocytopenic multi-system organ failure, is plasma exchange. And so I'm a little bit quicker to go to plasma exchange in those kids that meet criteria for TAMOF than I am to go to any of the cytokine modulators. It also, if I give a cytokine modulator and then decide to plasma exchange, I'm just pulling my drug off, so probably not much benefit. So typically, if I'm in that state, what I end up doing, if I decide I want to immune modulate, I'll go to plasma exchange if they meet TAMOF criteria, which this patient did because of the low platelets. And then at the completion of my therapy, I dose anakinra at that point. So, you know, that's a style thing, and that's just it. I'm trying to separate out my therapies to know, you know, give the body some time to tell me whether that's worked or not. So I go to plasma exchange pretty quickly.
Okay. Generally, it is said that when you are using immunoadsorption like oxalase or cytosol, the adsorption will remove the cytokines which are in higher concentration. So if you have a pro-inflammatory in higher concentration, that will be removed more. Or if you have an anti-inflammatory cytokines in higher concentration, they will be removed more. So if there is a confusion whether you are in a pro-inflammatory or inflammatory, anti-inflammatory cytokine, is it not a better strategy to just start an immunoadsorption therapy so that it will just remove whichever is in the higher concentration? What do you say?
We don't know. You know, that's really the big thing. The big question to answer is what is the underlying or the etiology for the dysregulation that we end up in? And if we lower pro-inflammatory cytokines, do we reset and reconnect that inflammatory state and the inflammatory regulation in the setting of critical illness? Now, there's a lot of theory out there, and in chronic inflammation, it's reasonable to think that if we modulate our cytokines, that we will reset the dysregulation, but we don't have that data, and we really don't know that data yet. My belief is at least it'll gain us some hemodynamics and help with organ dysfunction based on that data. But we may just be putting you know, we may not be getting at the root of the issue. So.
I think I would just want to add in, since I was kind of involved in the management of this child. So initially, he definitely had pneumococcal sepsis, going by the story that this child presented with. And in between, he seemed to have a sort of a honeymoon phase where he recovered and seemed to be fairly doing all right. And then he worsened again. So I think what we are finding challenging is when they apparently get better, probably that's the phase wherein they are in immune paralysis, or so it seems, and they catch another infection, which probably at times we may not be able to identify, and that drives the storm again. So when they come to us in the second storm, it's hard not to give them IL-1 blockade there. Probably steroids, yes, I agree, is something we probably shouldn't be considering. But in that setting, I think it's very challenging to know whether the pro-inflammatory or anti-inflammatory cytokines are up, because the child is definitely in the storm with the high ferritin. And then that's something we need to tackle as we go around looking for what the underlying driving factor is for the second storm.
Absolutely. Absolutely. That is a confusion. But in this case, we stopped everything for 2 days, sent all the cultures, nothing grew. And the child, when we started with all big guns, big antibiotics, antifungals, everything.
I mean, if it was a secondary infection, I think I would be less concerned about giving anakinra than the steroids. And the other thing I'll say about the late 80s, early 90s trials, again, TNF and IL-1 blockade didn't look like they work and may have caused harm in subsets of patients, but it also helped subsets of patients. So it's getting back to, what we've all been talking about, including Ed, figuring out who needs what, the precision approach. And here again, maybe even having cytokine panels to compare at the different phases of this child's disease ultimately would have helped guide some decisions one way or the other. And sometimes, no matter what we do, kids sometimes just don't make it, right? These are horrible diseases. And we're obviously trying to do the best we can for them. But, some things just are tough to treat.
Yeah, I agree with that. I think there are those patients out there that it will help, and I think that data is pretty clear and pretty evident for us. Unfortunately, we just don't have a great way to identify those patients at this moment. But again, in a kid like this, I think we would have definitely been going for anakinra, when the kid came back and exactly as you guys did. But I think that as we do that, we have to understand the risk that we're taking. And that's why I think it just really takes a multidisciplinary team approach to think through these things. And whether this was a secondary culture negative sepsis, once again, hard to say, but with the ferritins that high, with the hepatosplenomegaly, with the persistence, I'd be wondering if something else was going on, that just in the first round of tests and things like the HLH, the bone marrow, that may not have picked up. And I can probably pull 5 or 6 kids exactly very similar story that we struggle with as well. So I think our understanding and our ability to find which kids are going to benefit and which kids we may cause some harm in is still limited.
The other thing I'll say about anakinra, at least in my own practice, when we first started using it to treat some of these cytokine storms, I was very reluctant to ever stop it when I saw it help. And so it's not a short-term fix a lot of times. And sometimes it's just a temporizer and they need something else. But for the kids that it does fix, there are a couple of kids, I left them on it for like 1.5 years after they left the hospital because I was just terrified to stop it. Now I don't do that, but I do keep them on it after hospitalization. I rarely send kids home where the anakinra helped get them out of the ICU and the ability to go home without going home on some of it. And I'm not sure that's right for everyone, but I think for some it is. And I do think for whatever strange reason, whatever subtlety that got the cytokine milieu out of whack, even if you target one of those, maybe not even the central cytokine, you can often get it back under control, which is amazing to me because it's just an array of badness floating in the blood. But the balance, the immune system's pretty good at balancing itself back, but it may not be able to do that in a brief period of time, such that myself as a chicken, I tend to leave them on it for a while. Not as long, I don't leave them on for 1.5 years anymore, but I do, it's not just like, okay, you're done, let's take it off, see how you do.
Thank you. Hello.
Yeah.
Thank you so much. Hello.
Yeah,
Am
go
I-
ahead, sir.
Yeah. Thank you so much, Dr. Randy and Dr. Timothy, for joining with us. And there are some questions which have been raised in the Q&A box. So if you
Dr. Suma wants to ask, I think.
ask, yes. I saw one question from Dr. Suma.
Yeah, if I can just ask.
Yes, yes, please go ahead.
Yeah. I think in the last year, I've had about 3 children with this kind of waving pattern of HLH. They were initially treated at a different center and they were not settling, seemed to initially settle, then not settling, then sent to us. And in about 3 children, they had CMV reactivation, which we detected on a PCR, really high, CMV reactivation, really high RNA levels on the PCR. And treating the CMV actually put a stop to the cytokine storm. So I'm just wondering whether did you check the CMV reactivation at the second time when the child fled?
Can I also add one more point?
Did you check for a CMV reactivation at the time of the second flare?
This is for you, Dr. Farhan.
Hello? Sorry?
Can you, so Dr. Farhan, Dr. Suma would like to know, could you check for the CMV reactivation for the
In this
for the
case, we did
second?
not check.
Yeah.
I think we should have checked, yeah.
I think one of the points is also that in a lot of this bacterial sepsis, like you said, even if they are in immunoparalysis phase, it leads to a lot of viral activation. That's the reason Dr. Sumabalan is asking that it can cause reactivation of EBV, CMV, HSV, and that can actually drive the ferritin up again, and everything
Yes.
can go up. So that's the reason I think one of the things in the talk also the experts are trying to say is you need to figure out what exactly is driving the ferritin up. For example, like in yesterday's case, we discussed a necrotic bowel can drive the ferritin up, and it can cause cytokine storm. So looking for the source, and oftentimes in the late course of this bacterial sepsis, the viral reactivation could be a source for your cytokine storm coming back again. I think that's the reason why Dr. Sumabalan was trying to ask that question.
Yeah, it is possible. Yeah, I agree. I don't exactly remember whether we started Ganfaclovir or not.
Even
Monica,
adeno infections and
Monica,
HSV.
do you remember antivirals? Did we start, Monica? In the second test?
No, sir.
It is a good point. And there's data in adults of patients with various cytokine storms that if you have multiple active viruses, particularly EBV and CMV, the mortality is astronomical.
Yeah, and there's additional data for lymphocyte depletion in severe sepsis, which some people believe is the reactivation of CMV and EBV. So in severe cases, as your dysregulation continues to build, you get reactivation of your viruses, and those situations are associated with very high mortality in sepsis.
Point well taken. So if there are no further questions, Dr. Chandrika from
yes, I think we can
wrap up. So thank you. Thank you. Thanks once again, Dr. Randy, Dr. Farhan, Dr. Timothy. I realize one thing, that the challenges are same on both the hemispheres, Western and Eastern. The PICUs in the terminals, as I call our centers as terminal centers, one step above the tertiary centers, and it remains almost same. The cytokine storm keeps foxing us. Suddenly, in the last 2 to 3 days after attending these sessions, now I'm also thinking a lot from that angle, being a nephrologist. And it was really an enriching experience to listen to all of you. A case well presented by Dr. Farhan and Dr. Monica. And we always learn from our failures, from what we could not do, and always makes us better for what we can do for more for our kids. Amazingly well organized conference by Dr. Rakshay and Dr. Chandrika. Thank you so much for giving me this opportunity, and a big shout out and kudos to all of you. Over to you, Dr. Chandrika. For your...
I'll just take a word. So I think I thank all the chairpersons and speakers for a wonderful second session. And we are at the end of second edition of Cytokine Storm Conference. I would request Chandrika to pass last few comments, and then we wind up this conference.
Yeah, so I think we've had a great time over the last 3 days learning about the depths of cytokine storm and how we can manage these children better. And with all the experts that we have, I really hope next year we can make this a physical meeting and hopefully see each of you in person and have a much more face-to-face discussion about this intriguing condition. So I think with that, we can wind up the symposium, and I would really thank all of you once again for joining us. Thank you.